Well, thank you all for organizing the talk and inviting me. I am Andrew Mayer, as was just discussed. I don't have any conflicts of interest to report for the current talk. I just wanted to note that I am supported by several grants from the National Institutes and Department of Defense. I know we've been short on time, and so I just want to acknowledge up front all of the collaborators that have helped with the work that you're about to see, not only from the Mind Research Network and the University of New Mexico, but also several different sites across the country. And so my talk today is really going to be focused on why do we need biomarkers to understand traumatic brain injury. We'll be focusing on mild traumatic brain injury. I'm going to start the talk just giving a very brief overview of some of the current diagnostic and prognostic issues that we face in the field of traumatic brain injury. Then I'm going to switch to talk more about vascular and microstructural imaging markers that we've been looking at for almost 2 decades now. And so if we think about where we are today with mild traumatic brain injury, there's about 17 different systems for diagnosing mild traumatic brain injury. Crow et al. Did a big study a few years ago where they reported that there was almost 92% variance in terms of diagnosis when you compared these different systems. So it's a big problem. There's the use of many imprecise terms. You'll hear the terms concussion and mild and subconcussive and complicated mild traumatic brain injury, and they're all just words. They don't really have any underlying biological mechanisms associated with them. There's always been this tension between symptom-based diagnosis, that's how we do a lot of our diagnosis and most of our prognosis, somewhat surprisingly, versus what are known as clinical signs. And I'm going to talk about the importance of that. It's important to recognize that for mild traumatic brain injury, approximately 90 to 98% of CT imaging is negative. And so these are really individuals who do not have biomarkers associated with this. During the panel discussion, I alluded to the fact that the National Institute of Neurological Disorders and Stroke has recently convened a workshop to try and understand traumatic brain injury, not in terms of only the nomenclature that's being used, but also the classification system. And that is hand in hand with a recent paper that came back out from Silverberg last year. And so one of the core decisions that we're faced with, and something that we started looking at in 2005, was what's the difference between symptomatic and physiological recovery? When we published a systematic review as part of the Concussion and Sports Group Working Group, what we noted in 2017 was that there's very few studies that looked at both clinical recovery as well as physiological recovery. When we updated that consensus statement in 2024, we did acknowledge that now there was actually increasing evidence suggesting that indeed mild traumatic brain injury was not resolved fully within a couple weeks, which is what we had all been trained to believe from a clinical perspective. But there was this long-term sort of physiological changes that occurred. But the big statement from the group was, again, whether this is sort of the one and done philosophy that we talk about is a scar tissue, or is this an ongoing process, something more akin to a neurodegeneration? And so this is a schemata that Davin Quinn and I published a few years ago in Biological Psychiatry. It's just highlighting the quote-unquote dirtiness of traumatic brain injury, how it affects multiple cellular pathologies on very different levels. We have a lot of different imaging techniques that we use to try and understand these. But again, there's a lot of complexity when we talk about something that's 5 to 6 microns versus an 8 microliter cubic volume in terms of the resolution that we're looking at for imaging. The other important thing to note about mild traumatic brain injury is that it's a shapeshifter. And so this is, of course, the famed neurometabolic cascade from Giza and Havda back in 2001. Here you see that the biomarkers that would define traumatic brain injury and even a mild traumatic brain injury drastically change from the course of minutes to hours to days. This has been updated with new blood-based biomarkers, but it's basically the same story, and that we see this post-traumatic release of these proteins into the bloodstream that are believed to be indicative of a certain cellular pathology, but they all change just within the minutes, hours, and days and weeks post-injury. And so I'm going to wrap up my sort of brief motivation for why we're doing this type of work with the real clinical need. And that's basically understanding what happens when we see patients in the office. And when I was trained to evaluate patients, I was told that essentially individuals who reported symptoms, months post a mild traumatic brain injury, this was, of course, back in the late 90s, it was mostly a psychological entity. If we look at what came out of the Boston group, we see that with chronic traumatic encephalopathy, this is an individual who had multiple concussions, and upon his suicide, it was revealed that he had CTE in multiple different regions of his brain. He was only 25 years old. We can, of course, contrast that with Todd Ewen, who was a enforcer in the NHL for 11 years. He unfortunately believed that he had CTE, believed that there was no treatment for it, and so he took his own life. Upon autopsy, it was revealed that he actually, in fact, did not have CTE. And so that's what we need biomarkers for. We need to be able to help these people while they're still alive to say, you have something versus potentially this is something else like depression, which we believe is treatable. And so I'm going to switch gears a little bit now and talk about how we have been using imaging to understand traumatic and vascular injuries in the practice of mild traumatic brain injury and traumatic brain injury in general. We know that vascular injuries are an essential part of the neurometabolic cascade. Again, we've known that for almost 3 decades now. However, it's a relatively understudied aspect of the pathophysiology even to this day. When we look at radiological common data elements, we see that intracranial hemorrhages are the most common RCD reported across the TBI spectrum. And these are typically associated with T2 star and SWI findings when we look from a radiological perspective. However, there's been a little bit of a shift in terms of understanding what these markers actually measure. And so for all of the clinicians in the field, I'm sure you've seen a million images like this. If you saw this probably 4 or 5 years ago, you might say that, okay, I see this, punctate foci that's linear in nature on diffusion weighted imaging and hypo-intense on T2 star. That, of course, is diffuse axonal injury. What Griffin et al. Showed in a sort of a landmark paper in 2019 is that might not actually be the case. And so when he took these individuals at autopsy and did high-resolution MRI, as well as some immunohistochemistry on the tissues, what he found was that these regions of encephalomalacia, which we believed to be, again, indicative of axonal injury, were actually staining with Prussian blue for hemosiderin-laden macrophages. This occurred in conjunction with reduced myelin content, but in fact, there was negative APP stains, which suggests, again, that this is not axonal injury, but this is, in fact, a vascular process. One of the recommendations that's going to come out of that NINS working group, this is work that we've submitted, but has not been published yet, is that, in fact, we should not be using the term diffuse axonal injury in conjunction with these radiological findings. Now, it's important to note that that doesn't mean that diffuse axonal injury does not occur. It's just that these markers are not a good indication of that. And so what I'll do now is switch gears and talk a little bit about some data that we gathered from about 550 kids as part of 2 R01s. We essentially saw about 300 children with mild traumatic brain injury, about 7 days, 4 months, and 1 year post-injury. We also recruited a sample of about 225 healthy controls because we know that there's neurodevelopmental changes, and we're honestly trying to study change on change when we're looking at kids post-traumatic change and recovery versus what's going on in typical neurodevelopment. You're going to see a lot of different numbers being presented in terms of sample sizes. That's just based on when these data were published, and we're actually still working on analyzing the long-term, the 1-year follow-up visits. And so the first thing that I'm going to talk about is how we look at vascular imaging. Most people, when they think about research in vascular imaging, they think about ASL techniques. We actually switched to look at cerebral vascular reactivity. In the scanner, we expose kids to a carbon dioxide challenge. As we all know, carbon dioxide is a mild toxin. What happens when hydrogen ions start appearing in the blood is 2 things. First, there's a direct pathway in terms of on the smooth muscle cells. It's a potent vasodilatory agent, and that causes, obviously, the caliber of the capillaries, arterioles, and arteries to increase. But there's also a secondary pathway, and we heard a little bit about this in Dr. Fisher's talk earlier, in which vasoactive agents are released by the endothelial cells. And so we actually also see distension in the capillaries, up to about 15% distension, just as a result of these challenges. Dr. Bragan talked a little bit about the Monroe-Kelly doctrine, as well as the increasing role that is being paid attention in terms of these relationships between low frequency oscillations and the lymphatic systems. And this is actually a way that lymphatic clearance also occurs during sleep. That was a Foltz paper that came out in Science a couple of years ago, as well as in normal physiology. What we do is then we fit the end-tidal CO2 data with a regressor, a family of regressors, and we look at things like what's the delay in the brain response to the end-tidal CO2, what's the magnitude of the fit, and how sensitive is the vasculature to this potential toxin. And this is the results from about 100 kids with mild traumatic brain injury and 100 controls. What we see is that within several regions of the brain, there is a delay. So the vasculature responds more slowly post-trauma. This delay persists up to 4 months post-injury. But somewhat paradoxically, the vasculature responds in a more sensitive way. So it's more sensitive to this toxin, even though it potential toxin, even though it takes longer to respond. These two events occur in spatially distinct regions. The predilection is for the deep gray matter in the frontotemporal regions. These are, of course, the classic regions that have been implicated in the aggregation of shear stresses and trauma from mechanical models. And what we believe is that that this is evidence that traumatic brain injury, mild traumatic brain injury, impairs vascular tone as well as myogenic reactivity. We did look at autoregulatory function. This is a review that we published with Andrew Carlson, who was a neurosurgeon here at University of New Mexico. And again, Dr. Bragan showed some of this. This is a classic test in the clinic with severe TBI patients, but we don't really feel like autoregulatory dysfunction is something that's really prevalent in this group because of the length and duration of our hypercapnic challenge. We did see using PCASL that there was hyperperfusion in the bilateral cerebellum. When we looked at this, I know Dr. Keel talked about some balanced accuracy and area of the curve information earlier. These vascular markers only resulted in about 70% classification accuracy, which again is pretty low, but it's not really low when we talk about gold standards in the field, which are also around 70%. We have to remember that these injuries are sort of mild in nature and that we do expect that most people will eventually recover from them. And so the other important...
About a minute and a half, okay?
A minute and a half. Okay. I have 13 minutes on my clock, but so basically we saw no relationship with post-concussive symptoms, but we did see that there was a effect in terms of post-traumatic amnesia and loss of consciousness. And so I'll sort of go through this rather quickly. And basically everyone is familiar with diffusion imaging. It's dependent on the density of the neurites, the morphometry of the neurites in terms of their orientation in the free water content. Most people use diffusion tensor imaging, which is a linear fit. We use geometric models, which take into account the more complex microstructure. On this particular scan, we did 165 directions, which is, of course, high angular resolution imaging. And we actually came up with our own model of diffusion. We changed the intracellular versus extracellular diffusion and came up with our own parameters in terms of the preclinical literature rather than what had been published. And essentially what we showed was that our model was superior. It showed evidence of increased free water in the gray matter and increased orientation diffusion index within the white matter, suggesting that there was some issues in terms of how the microstructure changed after injury. And again, these things all persisted for 4 months. We also saw changes in neurite density And when we looked at this in relation to the ischemic stroke literature, we found that it was exactly the same. So just like in ischemic stroke, acute mild traumatic brain injury changes the gray water diffusion as well as white matter diffusion. In a separate, this was all stuff that we published in Brain. In a separate publication in Neurology, we also showed that the presence of post-traumatic amnesia and loss of consciousness also increases the atrophy within the hippocampal, and we actually just submitted a paper to Annals of Neurology here last week showing that this persists up to 1 year for that group alone. I won't talk too much about this because apparently I'm out of time, but this is our future direction. We're going to be combining microRNAs with blood-based biomarkers and imaging to try and understand mechanisms from a truly informed perspective. We also have several grants from the Department of Defense looking at the biological mechanisms of these injuries, comparing blood-based biomarkers to histopathology in terms of APP, IgG, GFAP, and a few other stains. And what our data suggests is that there's evidence that from imaging and blood-based biomarkers that things remain elevated up to 4 months post-injury, and that there is potentially this delayed physiological recovery or the potential, again, of the one-and-done scar tissue. These are not related to post-concussive symptoms, but they are showing a dose-dependent relationship in terms of injury severity. And so we think that this is sort of superior to self-report. And so, again, the field's rapidly changing. We're trying to understand how the brain changes from a single concussion to potentially permanent neurological damage. I personally don't think that this happens in every single instance of mild traumatic brain injury. We hope that biomarkers will eventually get us there, but again, probably going to be a little bit of a winding pattern. I think that is it. Thank you very much for your attention.